Good morning. I would like to thank the organizing committee for inviting me to give this talk of this important and underexplored issue. I will talk about the approach to TR during mitral valve surgery in both rheumatic and degenerative heart disease. I will talk about the timing of intervention. I will briefly show the guidelines, and I will talk about the innovative treatment that we could provide to such patients. Having TR is bad, as shown in these famous slides taken 10 years before, and having severe TR is very bad for prognosis, independent of age, biventricular systolic function, RV size, or dilatation of the inferior vena cava. There was a misconception almost 5 decades ago that TR goes away if you fix the mitral valve. This was based on a small study by Nina Brownwald, who was an American surgeon. 28 patients, short follow-up of 30 months, and a very rewarding operation. The pulmonary pressure was very high and got almost back to normal values. And the conclusion was that many patients with advanced mitral valve disease-associated TR is functional, and TR will improve or disappear after MVR, and the TVR is seldom necessary. Well, this was a big mistake, as we all know from further studies, where the follow-up was too short. There was no data on tricuspid valve anatomy. We don't know if this applies to patients without severe pulmonary hypertension, and what happens if pulmonary hypertension does not regress. 20 years ago, Alex Sagi showed in a small study of patients with mitral balloon valvuloplasty that severe TR does not go away if you fix the valve, either if the balloon valvuloplasty is successful or less successful. You can question if this does apply to mitral valve replacement, not valvuloplasty. Well, yes, if you look at several studies, the first one is ours and the other are from other groups, who shows in a remarkable proportion of patients with rheumatic heart disease and a follow-up of several years, the significant TR either is progressive or is de novo in a large amount, a large proportion of patients after mitral valve replacement. There will be patients in whom the TR will not progress or will resolve. These are the younger patients with non-organic tricuspid regurgitation etiology, with greater predicted benefit of mitral surgery, like those with very, very low preoperative mitral valve area, very, very high preoperative pulmonary pressure, and greater post-procedural resolution of pulmonary hypertension, and obviously those without atrial fibrillation. You do not want to get into a redo tricuspid valve surgery after mitral valve replacement. Previous studies had terrible results. Mortality of 25 or 50% in small studies. Later studies in the last decade show much better results. However, still I think it is something around 15 to 20% mortality. You better avoid reoperative tricuspid valve surgery. So what should we do? We should try to repair the tricuspid valve during mitral valve surgery, and the question is which patients, what criteria, and what is the penalty of repairing tricuspid during mitral valve surgery. I'll show you several studies. One of the most important is that of Gilles Dreyfus, who just measured the tricuspid annular diameter by putting 4 fingers or putting a ruler and finding a cutoff point of 7 centimeters, which is intraoperative, which is compatible with 4 millimeters diameter by echo. And what he was able to show that if he chose to repair the tricuspid valve by putting an annuloplasty ring according to the diameter alone, the recurrence rate or the grade of the TR after 5 years, almost 5 years, was almost none in those who had tricuspid annuloplasty. And when he did MVR only, there was a large recurrence rate over time. However, it did not affect not survival or events, and only one patient over these 5 years required tricuspid valve replacement. The conclusion of this study was that remodeling annuloplasty of the tricuspid valve based on tricuspid dilatation improves functional status irrespective of the grade of regurgitation, just only by measuring the annulus. But he did not perform any multivariate analysis to identify predictors of TR. He didn't ask for the impact of the etiology, like rheumatic heart disease, for example. He didn't look for the impact of atrial fibrillation or MACE procedure. And we can question whether the cutoff value for tricuspid annuloplasty was too high. On the other side, there was a large study made in the Mayo Clinic, almost 700 patients with only mitral valve prolapse who did not have any tricuspid intervention, provided that they did not have TR causing right heart failure before the operation or organic tricuspid valve disease. And when not touching the tricuspid valve at all, they were able to show that after the operation there is a little regression of TR severity. It rises a little bit over 5 years, but not to a considerable amount, and only one patient required TVR after 4.5 years. The predictors of TR progression in these studies were female sex, preoperative AF, and diabetes. So the conclusion was that clinically silent, non-severe TR in patients with degenerative mitral valve disease is unlikely to progress after mitral valve repair, and that tricuspid valve surgery is rarely necessary for most patients undergoing repair of isolated mitral valve prolapse. They did not analyze the impact of MR recurrence on TR recurrence, and they did not analyze the impact of tricuspid annulus. What should we do for rheumatic heart disease? There are no controlled studies. I think, and we think in our group, that 3.5 centimeters may be a more appropriate cutoff point for those with rheumatic heart disease. And there are some suggestions of putting a 2.1 centimeter per meter square, which is equivalent to 3.6 centimeters for an average sized person. Is there a penalty for concomitant tricuspid annuloplasty when correcting left-sided valve disease? This is an overview of 12 papers chosen out of 561 papers screened, showing that indeed it increases the cross-screen time, 57 to 83 without tricuspid annuloplasty, to 62 to 100 with tricuspid annuloplasty. It increases also the cardiopulmonary bypass time, obviously, with a mean difference of 20 minutes, which may be variable according to the expertise and the practice of the surgeons. There is no difference in mobility and mortality with and without tricuspid repair. So tricuspid annuloplasty is a low-risk procedure, and concomitant tricuspid valve repair does not significantly increase the perioperative mortality and morbidity when correcting left-sided valve disease. So this is a very important message, that you don't have much mortality or morbidity, so you should have a very low threshold to correcting the tricuspid valve by doing a mitral valve surgery. I will not get much into how to repair, but several sites to show that some ring or band should be put in. The durability of tricuspid annuloplasty without ring or band, like the Vega or H2H, is much less than those with a ring or a band. If there is a considerable apical tenting, the durability of a simple repair by a ring is much less than for those without apical tenting. There's a small study showing by Gilles Dreyfus that you can augment the anterior leaflet and get a much better result and durable results. The number, it was published 6 years ago, the number of patients is small, the follow-up is small, but it's very, very promising. What is the window of opportunity for tricuspid valve surgery in severe TR? Now let's leave alone the mitral, we're talking about severe TR. If you compare the guidelines talking about MR and TR, you can see that for MR we have New York Heart Association 2 or more. For TR, they should be symptomatic, but how symptomatic we don't know. LV function for intervention less than 64 MR. Progressive dysfunction, but no cutoff for TR. Ventricular size, left ventricular and systolic diameter 40 to 45. Progressive dilatation, but no cutoff. AF and atrial size are not mentioned. So there are much less data on TR than on MR. What is the definition of too sick ventricles for MR versus TR? Well, we're looking at the guidelines, ejection fraction less than 30 or end-systolic diameter above 55 are remarkable LV dysfunction for those patients with severe MR. What about TR? The guidelines do not provide us with tools to do that. There are clinical predictors of worse outcome following TR. You don't want to get into TR in advanced congestive heart failure, in a reoperation, with comorbidities, in an emergency operation, or concomitant intervention. There are echocardiographic predictors of worse outcome following TVR, for example, enlarged mid-cavity diameter of more than 32, RV longitudinal dimension, tethering area more than 0.85, RV dysfunction as noted before, and right myocardial performance index that's shown by Jan Tupilski several years ago in the Mayo Clinic. This is the sum of the isolobic contraction and isolobic relaxation divided by the ejection time. When it is very low, the prognosis of the patients is very, very poor. It was a better predictor of worse outcome compared, for example, to RV function as assessed by eyeballing. And you know there are a lot of parameters to assess the RV function. The fractional area change, which is what we see by eyeballing, the TAFC, the RIMP is shown before, the S prime, and so forth. But again, we don't have very, very precise data to show what is the right time to intervene into tricuspid in severe TR. And indeed, my experience, and I think most of your experience, you follow these patients, they are perfectly or near normally functioning. You see the signs of severe TR with the pulsatile liver and engorged veins, but no signs of volume overload, and all of a sudden they drop, they develop signs of right heart failure, and then it is too late. So we should widen the window of opportunity, and there are not much data regarding that. The guidelines were shown by Mr. Git in the previous lecture. I will just show you that for patients not undergoing left-sided valve surgery, the Americans are much less reluctant to intervene than the Europeans. For those with symptomatic isolated TR without RV dysfunction, it is 2A in opposed to 1. And those who are symptomatic or mildly symptomatic, again, it is 2B against 2A. Just one point to note about LVAD. About 1/4 of patients undergoing LVAD in the STS database underwent tricuspid valve procedure. You should expect that the tricuspid may regress, TR may regress after unloading the left ventricle. It may or may not be true. There was no effect on death or RVAD requirement. However, it had an adverse event on the acute kidney injury, reopened, blood requirement, and hospital stay. And their conclusion was that data are against routine concomitant tricuspid valve procedure based solely on the degree of preoperative TR. Another important point to mention is the role of atrial fibrillation in TR progression. This was a study that was done in Carmel, was published this year, showing that in contemporary data of patients without rheumatic heart disease in 5 years follow-up, that having atrial fibrillation or pulmonary hypertension is predictive of TR progression, and if you have both of them, the odds of progression is very high, and that's why in such patients, we should consider rhythm control over rate control in order to avoid progression of TR. The last topic would be percutaneous solutions for TR. Some patients are too sick to undergo tricuspid valve surgery, and there are some innovative solutions. First one is a heterotopic transcatheter tricuspid valve implantation. You can put a valve in the inferior vena cava, you can put a valve in the superior vena cava, you can put a valve in both. And there are some data to show that this may be rewarding. This is obviously very, very preliminary. This is a study done with Edward Sapien valve. 3 patients, all improved at least by 1 New York class. The signs of right heart congestion decreased dramatically, the RV function improved, and the volumes also improved. It is very, very problematic. The anatomy is complex. There may be a short segment between the right atrium and the hepatic vein ostium, and if you don't want to obliterate the ostium, the diameter of the cava may be enormous. We have patients with 3 or 4 centimeters of inferior vena cava. So some of these valves are custom-made. Sometimes you have to put additional stents in order to put the valve inside. And there is a report of surgical IVC bending through a mini operation in order to enable valve implantation. There may be a problem with pacemaker wires if you put the valve in the superior vena cava. This is a low flow, low pressure chamber, so you should use lifelong anticoagulation. There is no outlet for the right atrium. We don't know what it does in the long term. The follow-up is very, very short. There is a very innovative procedure called TRAIPTA, in which by percutaneous procedure you perforate the right atrial appendage, and then you put a snare in the AV groove. Obviously, you do perforation of the right atrium, so you should close it percutaneously by a device. This looks frightening, but there is an ongoing trial examining this procedure. There's also an application of the Mitralign. It was used for the mitral valve, for the tricuspid valve. This is a kind of commissuroplasty. Again, this is very, very experimental. We have an opportunity to put a valve in a valve in degenerative xenograft. There are several dozens of cases in the literature using mostly Sapien or Melody valves. The approaches may be transfemoral, transjugular, or transatrial. It is not very, very trivial. We have to do balloon sizing sometimes for the TS. We have a problem with patients who have a pacemaker leads. And there are obviously size issues because some of the tricuspid valves are really so huge that you cannot put a commercial valve inside. This is our case of a patient who had severe TR. We put a valve in valve, Edwards, in a Hancock 1 graft, and we saw a rewarding and a very, very impressive improvement in this patient. There are several ongoing trials regarding TR. We'll finish in a moment. There are 2 trials now all over the world examining the role of tricuspid annuloplasty for moderate TR associated with mitral operation, and there are several other studies in this issue, not as much as I would like to. I would just want one minute to state the Israeli contribution both in my institution, predominantly by Alex Sagi and Moti Batur, who also helped me in this lecture, and by other centers, Rambam, Sheba, Carmel, and Ichilov. And the conclusion is that TR carries bad prognosis. TR prevention is advisable by aggressive approach during left-sided surgery and probably by rhythm control for AF. We should address TR before RV fails and before patients reach New York Heart Association 4. We need further studies to define the window of opportunity for tricuspid valve surgery, and we may use innovation to help no operation or high-risk patients.